So I want to talk about one other aspect, which is not exactly watchful waiting until you need to treat, but kind of treatment holidays, which is also, giving a person an upfront TKI. So these are, you treat a person, they have a nice response, they've been on therapy for an extended period of time, and you start to think, well, maybe some time away from drug might be a reasonable opportunity for this person. What's the Anderson approach to that, and your personal approach?
I think the obvious is if a patient rarely achieves this complete response. It's 1% of the patients on sunitinib or pazopanib. But even those who achieve a good partial response, and they have to begin with lung, pancreatic, endocrine, other endocrine like thyroid, the ones that we know are indolent by biology, those are perfect patients to tell them, yes, it's good to take a drug holiday. I think if we have treated them for many years already, they've survived 4 or 5 years, then I think these are the patients who are also perfect candidates for an extended holiday. And when they progress, when they, on either subsequent scanning or they decide, well, I'm nervous now, I want to resume therapy, then I think we resume. And I do not believe these patients are in any way harmed by these extended drug holidays. They're still, I think it's the biology primarily that let us feel that we can give them these drug holidays.
So we have two populations of opportunities for these patients, Dan. We have a group that maybe you don't start right away, and a group that benefits and maybe you don't continue forever. How do you manage those decisions?
I'd put one more in there, and that's the metastastectomy patient, which we still do, those patients with this oligometastatic or single metastatic site that will resect. And again, sort of the goal here is getting to a complete response. If we can do that surgically, if we can do that through stereotactic radiosurgery or cryoablation, RFA, we'll do those kinds of things in certain cases as well. Again, with the goal of being able to delay the time to systemic therapy.
So let me just interrupt for a second, because I know Monty's doing that trial in the cooperative group. And that is, but in your practice, when you have oligometastatic disease that you treat through some manipulation, local regional manipulation other than systemic, your approach then is to watch them as opposed to jump in and start treating them at that point?
That's exactly right. I'm not saying it's wrong to start a systemic therapy. At the end of the day, they are metastatic. But that's the kind of patient I feel comfortable we can watch. We're going to do scanning on a fairly regular basis every 3 months to start, to make sure there's not sort of a more rapid progression of disease, particularly if we have treated them with systemic therapy prior to that. But if we can get them to a complete response or near complete response, and we're pretty comfortable with the minimal disease burden, that's a really nice time to take a treatment break.
So Monty, that's the cooperative group trial, isn't it?
Sure. We always talk about the ongoing adjuvant studies, and one that probably doesn't get as much attention as ECOG 2810, which is a randomized study comparing pazopanib and placebo. It's led by Len Appelman, who have received metastasectomy. That study acknowledges the fact that in this population of patients that Dan's alluded to, the disease-free survival at 3 years is actually less than 50%. Very high risk for recurrence, and I think that in terms of a trial that's enriched in the adjuvant setting for outcome, I think that this is a perfect example.
Just to put some numbers around it, Brian, and I'll weigh in also in terms of my practice, but what's the range of treatment holidays that you've seen for patients in your practice, from how short to how long before you've had to retreat? And then I'll ask our colleagues to weigh in as well.
Well, I guess I'd say two things. So in our sort of anecdotal retrospective experience, I know there were patients who were watched probably over 3 years. Every time I see those patients, I go back and make sure that they actually had metastatic kidney cancer when I started to treat them, and they did, thankfully. We also have a prospective experience where we've had people go on drug, take a 10-week break, and then when they regrew, restarted them. Now we've had 3 of about 20 patients who never regrew, and they're about 10 to 14 months out. So it's just an unusual disease, and you got to take advantage of the biology when it's favorable. That's how I'd put it.
Monty, what's your experience? Kind of what's the range?
Yeah, certainly a smaller experience than Brian's, but I have had some luck with prolonged treatment holidays. I think perhaps the longest holiday that I've offered is close to 4 to 6 months, but thereafter I did see some tumor growth and restarted therapy.
Dan?
Yeah, I have a few of these patients that are 3+ years out, and typically the ones that have a really pretty near CR response or CR response, and those are those are the cases where you just wonder, was something different about their biology to begin with?
Well-
But on average, we do see, patients that we take a break, summer they want to take a 3-month break or whatnot. And I agree, for the most part, we haven't run into trouble. I have had a couple cases where we've seen more, dramatic progression during that 3-month period of time. So I do caution patients about that. I am kind of, a little bit leery if they have symptoms, particularly pain, that we want to see them back right away.
Yeah, and we've actually had a very similar experience, and I know Brian and I have published on this separately, but one could ask the question, are these sunitinib TKI patients? Is there a immunologic something that is going on that is allowing them to have a prolonged remission that is out of proportion to just an anti-VEGF effect? I'm not sure we know the answer to that, but certainly there's patients. And I think the good information for our practicing physicians is to have the comfort in patients that have lower risk to wait before you start, and to have the comfort after an excellent response to therapy to give them a break and allow them to continue and watch them carefully and restart when the appropriate time comes. And I think we've done that. Brian?
Just maybe one more comment about breaks in a different light is, and we've had mostly experience with axitinib, is that giving people a 2 or 3 day break every once in a while really recharges their batteries, really resets toxicities, especially diarrhea. And it doesn't just reset it for 2 or 3 days, it's sometimes 2 or 3 weeks or 2 months.
Right.
And so most of our patients, especially on that drug long term, they'll take 2, 3, 4 day break every 4, 6, 8 weeks, almost all of them.